How do we inject different types of lesions? You have a total volume you're allowed to inject, which is up to 10 cc's. I inject the biggest lesions first until we are done injecting the total volume. Depending on the size of the lesions and how many lesions the patient has, according to the chart, which dictates volume of injectate per size and amount of lesions, we'll use different types of syringes and different needles. If we had a patient that had multiple in-transit lesions, such as you can see here, I would have the dose calculated. Let's say these 4 lesions will take a total dose of 1 cc, either 0.1 or 0.5 cc's per diameter of the lesion. You would have the injectate in here. You would swab the area down with alcohol. We would have a 4x4 so we don't spray it onto the patient. And then I would go from lesion to lesion. Again, I would insert the needle at the very edge of the lesion, get it in the lesion, and start injecting as we pull it almost entirely out of the lesion, but not inserting it in through a separate stab incision, and inject through a fan technique. Gently aspirate as you remove the needle, and then you go straight to the next lesion. For the subcutaneous lesions, we're going to use a bigger needle. And again, syringe filled up with the amount of volume that would be appropriate for the diameter of the lesion. So we're going to go on the very edge of the lesion. And again, we're going to use a fanning technique where we take the needle out and redirect it in a fanning technique to cover the entire lesion. At the very end, we gently aspirate on it just to make sure that it's not going to leak out. And again, we wipe it down with alcohol, Mastisol, Tegaderm, and we're done. Some of the difficult lesions that we inject are the ones that are ulcerated. In this case, we're going to try to target those solid areas of the lesion. So I'm using the longer needle so I can get it through a single insertion site without having to reinsert the needle in numerous different areas, because these needle holes are just going to cause other tracks for the virus to leak out. What we're going to do is we're going to go a little deeper than the ulcerated portions of this lesion, still getting it into tumor, but we don't want to be so superficial that all the injectate comes out of the ulcerated surface. So I'm going to go a little deeper, and using a fanning technique, I'm going to distribute the amount of injectate through the entire lesion. And as you can see here, I can inject this entire lesion through a fanning technique without withdrawing the needle. And then again, we gently aspirate. We wipe down afterwards the entire lesion with an alcohol wipe. We place Mastisol around it, and then a Tegaderm that goes on top of that, and that stays there for 7 days. Have the patient put EMLA cream on, which is lidocaine cream, on their lesions. They can cover it with a Tegaderm at home, or they can keep it open. And I have them put it on about 45 minutes prior to their appointment time, so the area is somewhat numbed up. What we don't want to do is inject these tiny little areas where we're going to move from lesion to lesion with the virus with any sort of lidocaine. Because remember, any needle hole that we have in that area, if we were to numb it up with lidocaine, is another needle hole or needle track that the virus is going to leak out of. So the patient comes into a treatment room in clinic. Usually we don't have them in a chair unless it's a scalp lesion and they can be sitting up. If it's not really a scalp lesion and it's extremity, we usually have them lying down on the bed. They get draped out with just a regular sheet and their affected portion of their body exposed. The virus is already loaded in the syringes based on our table that will correlate diameter to the amount of injectate. We don our PPE, wipe down the patient with an alcohol prep, and then go lesion to lesion, wipe down the patient again, and place the Tegaderm. After the patient leaves the room, we wipe down the bed with a Cavi wipe or a sanitizer wipe. We wipe down any surfaces that were used with the virus, and then we're ready for the next patient as soon as that dries. So we usually schedule them in half-an-hour blocks. Patients in the room for about 10 minutes. The injection takes about 5 minutes. Wiping down and preparing for the next patient could take about 20 minutes, and then we're good to go. At our institution, the surgical oncologists are usually the ones that inject, or our APPs. We have a bunch of amazing PAs at our institution who have been trained by myself and my partner on how to inject. They take a chemo course on how to order it, and then they perform 20 injections before we sign off on them. They record all the injections, we sign off on them as a proctor, and once they've injected 20 patients, they are good to go without our direct supervision.